Good morning, everyone, and welcome to this Health Foundation webinar looking at the experience of the Directors of Public Health and their teams during the COVID-19 pandemic and the implications for the public health system. It's really nice to have you with us this morning and to have our excellent speakers who I will introduce in a second. The last 18 months have been life-changing and career-defining for public health teams across the country. And we're here today to talk about what it was really like on the ground for public health teams and what the lessons from that period mean for us as we go forward with the COVID response, with the new central public health structures, with a new focus on levelling up, and with a new public awareness of health inequalities, among many other things in the landscape at the moment. Although COVID-19 is still with us, now does feel like a good time to reflect on what happened, what we've learned, and what lessons we can learn as we move forwards. I'm Catherine Merrifield. I'm a Job Share Assistant Director in the Healthy Lives team at the Health Foundation. And as I said, I'm joined today by an excellent panel who are going to bring different insights and experiences. Fuller biographies are available on our website that relates to the session today, but I wanted to briefly introduce everyone that you're going to hear from today. So on the panel today, we've got Shilpa Ross, who is a policy fellow at the King's Fund, who led research funded by the Health Foundation, looking at the experience of public health teams during COVID. She's going to give us an overview of the findings to start the conversation off. Shilpa's also worked recently on volunteering, mental health and transformational change in the health and care system. So I'm sure she'll have lots of excellent insights to bring today. We're then going to hear from Professor Jim McManus, who is Director of Public Health for Hertfordshire County Council and Interim President of the Association of Directors of Public Health. In Hertfordshire, he's responsible for England's 5th largest public health system, and he's also the Prevention and Population Health Management Lead for his integrated care system. And he's going to be giving his perspective today as a Director of Public Health. We're then going to hear from Robin Tuddenham, who's Chief Executive for Calderdale Council and the Accountable Officer for NHS Calderdale Clinical Commissioning Group. He leads both the Council and the CCG workforce. He's also the lead for Improving Population Health Programme for West Yorkshire Health and Care Partnership. And he's going to be talking to us today about his experience of working with the public health team in his council during the pandemic. And last but not least, we're going to hear a regional perspective from Professor Kevin Fenton, who is Regional Director of Public Health for London at the Office for Health Improvement and Disparities, which I'm sure he's now learning to say in his introduction, having only been in that role since the 1st of October, obviously since the recent changes, which I'm sure we'll be picking up today. In his role there, he's also Statutory Health Advisor to the Mayor of London and the Greater London Authority, and he took a leading role in London's response to the COVID-19 pandemic. He's going to be sharing his reflections today on how fundamental the relationships are between local and regional levels and how we can strengthen this going forwards, among other things. And at the very end of the session, we're also going to be hearing a video, well, watching a video of a very powerful reflection on the pandemic, which has been written by Alice Wiseman, who is Director of Public Health for Gateshead, and it's read by Alice and Directors of Public Health for Croydon, Walsall, Hackney and Bolton. So we've got a real treat in store for us today, lots of interesting perspectives, lots of interesting things to talk about. Before we get to the meat of it, I just wanted to pick up a couple of housekeeping bits. We are aiming to finish at 1:15 at the latest. The event today, like all Health Foundation webinars, will be recorded and will be available on the website around 24 hours after the event finishes. So if you want to watch back and think further about what we've talked about, or you want to recommend it to friends, please do that. It'll be available. A big thank you to people who have pre-submitted questions. We'll try and get through some of those. There's also the opportunity during the session to ask questions, so please do use the Q&A box at the bottom of your screens to ask questions. As well as asking questions, do look at questions others have asked, and I'd encourage you to upvote questions so that I can see the questions that there's a real interest in focusing on. Finally, if you'd like to tweet about this event, it would be great if you could use the hashtag #AYearLikeNoOther. That information hopefully was on the screen at the beginning of the session, so you've got that as well. So I think we're ready to get started. Firstly, we're going to hear from Shilpa, who's going to talk us through the headline findings of the report, and she has got some slides which are up on the screen. Thanks very much. Over to you, Shilpa.
Thank you, Catherine. So hello, everyone. My name is Shilpa. I'm a fellow at the King's Fund. Thank you so much to the Health Foundation for the kind invitation to take part in today's webinar, and moreover for supporting the research study. I'm delighted to be speaking on behalf of the project team today. I'm sharing a very quick canter through the main points from the research study. Next slide, please. So there is little research about how local and national systems have responded to large-scale crises such as the COVID-19 pandemic. Directors of public health have a key role in protecting and improving the health of their communities, including infectious disease control. Through this research study, we wanted to tell the story of COVID-19 through the lens of directors of public health and their teams, a key part of the story of COVID-19 in the UK that might otherwise be overlooked. On the next slide, there's a quote from a director of public health, which sums up this point. Next slide, please. I'll be very brief about our methodology in this qualitative study. We drew heavily on interviews with people involved in the COVID-19 response at different levels in England, Northern Ireland, Scotland, and Wales. What really made this research possible was a group of directors of public health who very generously gave us their time to speak on up to 3 occasions over the course of the fieldwork period. Can I have the next slide, please? So I'm going to take you through the findings in a second. This is where viewers can access the full report or short summaries. Next slide, please. So firstly, it's important to note the context the local public health system was operating in. Before the pandemic, public health was heavily impacted by longer-term reductions to the public health grant, about a 24% real terms cut per capita since 2015 to 16. That's thanks to the Health Foundation for their analysis. And there have been wider cuts to broader spending in local government that affect the wider determinants of health. And as with other sectors, there were workforce shortages in public health too. We started our interviews in September 2020. Our interviews with directors of public health and other leaders based in local sites gave us a good sense of what directors of public health and public health teams were doing to stop the spread of COVID-19 and to support communities with the wider fallout of the pandemic. In a second, on the next slide, it gives a sense of the wide range, sorry, if you could just go back a second. It just gives a sense of the wide-ranging issues faced by public health, by the public health system in the course of the pandemic. The directors of public health we spoke to generally felt they had a degree of local preparedness in terms of established plans, and local resilience forums to draw on, with strong working relationships in place, and of course their core expertise around public health. However, what they hadn't anticipated was the length of time that the pandemic has gone on for. And almost all of that time has been focused on COVID, leaving little time and energy in the local public health system for the more routine public health issues. Next slide, please. Thank you. Next slide, please. The pandemic offered new ways and opportunities to engage with local people. The directors we heard from described a wide range of support and engagement activities they've helped deliver during this period. They've spoken about how they, with their communities, have modelled new ways of engaging and working in partnership. We heard about several examples of public health teams working with partners such as the local voluntary sector, community and faith groups, and local businesses to support, to deliver support. The community champions are a great example of this. They played a key role in working with the public health teams in myth busting and spreading health messages across communities. Understanding the community's needs was described as key to help support local population testing and vaccine uptake. Having the understanding and intel from the communities they support allowed directors of public health and their teams to target areas where there was lower uptake of testing and vaccination. However, there was a real concern amongst directors about sustaining this type of engagement with the public into the future. As the pandemic has rolled on, there've been several challenges in keeping momentum going as COVID fatigue sets in, as well as the impact of national messaging and explaining new guidance and concepts. The key takeaway, however, is the importance of local knowledge and nuanced approaches to engagement with local communities. The directors recognise the limits of a one-size-fits-all approach and understand how to effectively and consistently hear from their communities. Next slide, please. And on this slide is what a director had to say about contact tracing and the knowledge and understanding that public health teams and directors have about the local population and how to engage with people. Next slide, please. So directors shared fairly openly with us how different factors impeded their efforts in tackling COVID. What stood out from earlier interviews that we did was directors not feeling that they always had a direct line to the Department of Health and Social Care to voice concerns that they had, for example, about difficulties in the local implementation of national plans. And as I've mentioned earlier, public health teams were focusing almost exclusively on COVID and operating with workforce shortages too. The COVID-specific funding that was made available was welcomed. Directors used this to increase their team size, invest in the local voluntary sector, build test and trace capacity, but it also highlighted the issue of wider lack of resource. Actual people available to hire with the right skills and experience. Directors described how they were fishing in the same pond for recruits and the difficulties they had in spending non-recurrent funding. So this indicates a need for a longer term attention to the capacity and resource that's available for local public health teams and ensuring that this is sustainable. Next slide, please. So the pandemic has actually increased the public profile of directors of public health. Their skilled leadership of the response has been noted by other leaders in the areas in which they work. And their leadership has helped build trust in the expertise and skill within local public health teams. So one director of public health described this change as feeling like going from a voice on the sidelines, trying to make the case for public health and its role in tackling the wider determinants of health, to being actively drawn into discussions and decisions about local strategy, having their voice really heard in ways that didn't always happen before the pandemic. Next slide, please. So multiple opportunity costs were described by the directors because of the focus on managing the immediate issues related to COVID. Some of the challenges brought to light by directors was their capacity earlier in the pandemic to engage in conversations about wider impacts and the future because of the immediate consequences of COVID mortality. They spoke about business as usual being on pause to different extents. Some had found that the COVID response had merged into business as usual, while others described a clear distinction between the two. Nonetheless, there were still discussions about the several impacts on public health service delivery. So, for example, services around managing obesity or smoking cessation support, and the impact that this would have on their population. There is a view that the full extent of the wider impacts have not yet been fully felt, but the emerging picture includes rising unmet need amongst the public. Next slide, please. So this quote from a director reflects the keenness that directors have to see a continuation of the central role that they have played. Now that health inequalities have registered on the radar in ways that perhaps they hadn't before the pandemic, directors really see their continued input as necessary to develop and guide approaches to tackling health inequalities. Next slide, please. So finally, I want to highlight some of the implications of what we learned through Directors of Public Health during COVID. So as I mentioned previously, there have been some profound impacts on different aspects of life and healthcare. It should also be noted that people have been working solidly and working harder than ever throughout the past 18 months, which has led to exhaustion. During the pandemic, there have been fundamental changes made to the public health system at a national level, with 2 new bodies being created and needing to bed in. But overall, the experience of the past 18 months shows that directors of public health teams can and should have a much more pivotal role post-COVID across health and care. So that was the very quick overview. Thank you so much for listening. Final slide.
Thank you, Shilpa. That was a fantastic run through what is a very rich report that I would encourage people to have a look at. Also to say those slides that Shilpa has just presented will be available on our website later on today, so do have a look at those as well. So thank you again, Shilpa. I'm now going to turn to Jim to give us his perspective as one of the people who was really living that experience that research was looking at. So Jim, over to you.
Thank you. Yeah, I had hair when we started COVID. I used to joke about in the times BC before COVID what we could learn, and I think this report is remarkable and of enduring significance, and Shilpa has summarised it very well, but it doesn't replace reading the whole report, which I commend to you. Being one of the critical friends of the report was for me a very valuable experience because I saw just what people did locally. We didn't learn, I think, all of the lessons from 2009. And the benefit of this report is that it captures learning that otherwise we wouldn't have got, because the 2009 learning spent an awful lot of time capturing national, not local learning. So for me, I couldn't be happier that this report's been published. And I guess there's some key take-homes from me. The first is there are 2 things in the world of public health policy, usually spoken about by people outside public health, that I find really unhelpful. The first is short-termism. You can't do public health on a short-term basis. And there's an awful lot of faddisms and new ideas. You know, somebody's got to have a hot take. And the problem is most hot takes congeal. And the second is the idea that public health is there primarily to help the NHS. It isn't. Public health is there to help the quality of life of the populations we serve. And this report sits in a long chain of reports from the Health Foundation and the King's Fund about the value of public health since it's come into local government. So, big message for me is that a director of public health and their team is not just for COVID. They have multiple roles as part of local infrastructure in health protection and in health improvement and in a variety of other things. And given that we will have further human disease from climate change, they're important for local infrastructure as well. I say the same thing about environmental health, because actually the dichotomy between public health and environmental health is historical. I couldn't have done my job without environmental health. They were every bit as important to me as my arms during COVID, and every bit as fantastic as anybody else. If we had cut environmental health or public health any further than we had in 2015, we would have been in some peril. I have to say that. So we have to advocate as part of a public health family of public health and environmental health. I think that means if you take them in regulatory services, it's all the more important that chief executives and councils should resist with every fibre of their being public health being pulled out of local government, because actually the evidence is that it has been more effective and valued within it. So let's deal with that issue about public health and the NHS. As Greg Fell has said, the NHS didn't understand public health when we were in it. And it's important to deliver a public health that does stuff for the NHS, but it's equally important to deliver a public health that does stuff for social care, for childcare, for sustainability, and for local government and for local systems. And that's where we need to reorient. And this report gives us a valuable opportunity to actually reset that order. That brings me to my next reflection on Hertfordshire. So we went from a team in public health in the county council of 64 to about 160 people in about 3 months, not counting the massive expansion of environmental health officer workload. And how we did that was we did become a team of teams. We have 11 councils in Hertfordshire and a police and crime commissioner. All of the leaders of all 11 councils meet every fortnight now. They met weekly during the pandemic. I still remember we had our first webinar and we used the University of Hertfordshire technology because we didn't have it. And we had over 1,000 head teachers and governors on a webinar at the beginning of the pandemic before anybody had heard of this newfangled thing called Zoom. Our webinars for elected members have never had fewer than 350 elected members on them. And elected members are the silent army of public health, which is another reason why we sit better in local government than in the NHS. From fortnightly press briefings to 500 community champions to elected members standing outside schools, reassuring staff and parents, actually the beauty of local government and the importance of public health and environmental health set into that local government system came into its own. And I think this report highlights that. Moving on, I think it encourages me to say that actually we have a massive opportunity to reflect on the value of public health for the local system. And the primary place of leadership in that local system has to be with local government, because they are about place, we are about place. And we need to reflect on that going into the ICS. Clinical public health is really valuable, but it is one bit of what public health does. And every single thing we do to make our local places more sustainable is every bit as important as actually cutting preventable amputations from diabetes. That report gives us the opportunity. Last couple of points. This morning's select committee report, which if you've managed to read, reinforces everything Shilpa has just said. National does not work without local. Local does not work without national. At local during the pandemic, we, our teams, so not directors of public health only, but our teams, I am nothing without the partners and colleagues I work with, made things happen, and we were the glue. We need a change in culture of how national works with local. That needs to be put into the exit strategy from COVID. And a final word about the model of leadership. There is a valuable model of leadership from the Health Foundation, which was developed with Ashridge, that balances the interpersonal, the technical, the personal, and the contextual levels of leadership. I really firmly believe that those of us who learned from that managed better in the pandemic because we realized our weaknesses and our limitations. And for me, I couldn't be prouder than serving. I mean, I don't ever want to work 14 hours a day, 7 days a week for 60 days without a break again, because COVID was not unprecedented. We were unprepared. This report helps us avoid that in the future. I'll leave it there and thank you for listening. I hope that was within time.
Thank you very much, Jim. And yeah, lots of themes starting to come out here that I think will probably nicely segue into what Robin's going to talk about the power of local. So I won't say anything else, Robin, I'll just turn straight to you.
Thanks, Catherine. And I mean, everything that Jim said, I'd start with. I'd also start with a huge thank you to every single public health practitioner on this call. We owe a huge debt to all of you, everything you've done, and I'm certainly determined to take forward one of the messages from Shilpa's report about not losing sight of and the recognition of the key role of public health in public services forever from this experience we've been through. I'm just going to talk about 4 things in the time I have. I'm going to talk a little bit about place, a little bit about evidence and systems, a little bit about doing the right thing, and then finally, what next? So as Jim has said, the power of place has always been something core to public health, and public health core to place. There's a great line I've stolen from Barry Quirk, who's another chief executive in London, who says, "It's possible to avoid doing almost anything, but not possible to avoid being somewhere." And the somewhere that you're in has a real impact on your life. Somewhere that you're born, the neighborhood that you're in, the communities that surround you, has a fundamental impact on your life. And public health practitioners get that. Local government gets that. And we need all public services to get that a bit better. And this isn't new, is it? I mean, it's not even just about the last 10, 15, 20 years. Public health, and when I talk about local government, I start with public health. I talk about 1848 Act that created these public health boards that were kind of a bit of business, a bit of a doctor, and a bit of elected councillors who made it their task to do what we'd call today environmental health, which is actually going in to factories to ensure that the conditions were safe, provide sanitation, water that was safe to drink. That's where local government began. So local government began as a public health function, and I still see it that. And public health is, I know it differs in different places. The Director of Public Health has always reported directly to me as Chief Exec. They're a person I see doing strategy, thinking and doing in a way that's quite unique in local government, and I would certainly fight tooth and nail to retain it, even though I sort of talk here from a joint role in the NHS as well. Because that public health function brings system thinking and evidence into what we do in local government and in public services. And doesn't the pandemic show everything that worked well was because we thought as a system, and everything that didn't work so well was when we forgot the system. So some of the issues around discharge, social care, the way we had to catch up in some of the impacts was some of the impacts of not thinking well on system, not understanding behaviour of our communities well enough, not knowing what we already know. I was in a conversation with Kevin last week, and we were talking and reflecting on, actually, I think government didn't understand and was shocked at how the public responded to the lockdown. And yet there was a lot of evidence from inside that could have helped shape political thinking more, and we've got to build on that. And the way we worked as a system, not just in place, but in West Yorkshire, where I work as the LRF and the ICS, and how that will take us forward. Third thing is doing the right thing. I think public health for me in local government in particular was fundamental in having the boldness to do the right thing at the right time. So the one example I'd say is supporting the homeless, those living street-based lives in the pandemic. So when the letter came about everyone in, we chose not to do that in Calderdale. We didn't put people in hotels. What we did was develop we shifted power to a voluntary sector provider called Gathering Place. We worked with, and I say we, it was public health team in particular, worked to create a wraparound service, learning from the stories that became our strategy from a Burnt Bridges report that we've developed on those that actually died living street-based lives just before the pandemic. And we created a wraparound service where the VCS was running it with public health advice, thinking about what do we need to do to stop homelessness and give people alternative lives. And that was system thinking, but it needed public health to support us, to make that real, to give it credibility, and for us to be prepared to take the risk. And finally, I'll just end with what we do next. There's a lot of work, language around building back better, levelling up, or whatever you feel about all of that. It's about inequalities, it's about health inequalities. It's about disparities in our communities, not just regional. It's much more than a north, east, south thing. And it's actually going to be with us for a while, I think. This government's very serious about levelling up. And we need public health to inform that, because what there isn't is a clear plan. And I'm really keen to see public health practitioners and thinking inform what happens next, because actually that plan isn't written yet. And this is not just about an economic levelling up. It's about how we feel about our place, where we live, the cohesion in our communities, the civic realm. And we need some work around some investable propositions based on evidence, based on system thinking. And I really think public health is key to informing levelling up. So I'd really urge all of you to be in those conversations, be bolshy, be awkward, knock down the doors, and actually be informing what we do next around levelling up. Thank you.
Thanks, Robin. Yeah, and we were pleased to see that Sajid Javid in his speech at Blackpool did acknowledge that need to link levelling up health with levelling up economically. But yeah, we're all eagerly anticipating and awaiting the levelling up white paper to understand how health is going to be embedded in that. So yeah. Thank you, Robin. That was really useful, and again, it's given us lots of food for thought. I can see lots of questions coming in, so just a reminder to add any further questions to the list, or indicate ones that you'd particularly like to see answered. So thank you to everybody who's doing that. And I'm now going to turn to our final speaker, Kevin Fenton. Kevin, over to you.
Great, thank you, Catherine, and good afternoon, everyone. It really is a pleasure to be here with you all this afternoon, and I want to begin by thanking Shilpa and the Health Foundation team for an excellent report, and having allowed us to take the time and space to reflect on the shared experience and the profound experience that we've had over the past 2 years, and how it has fundamentally changed the way we work, the way we're perceived, our role in local communities, national society, but most importantly, how we work as system leaders to help to both tackle the pandemic and build a foundation for addressing many of the large health issues which we'll have to deal with as we recover from and emerge from the pandemic. I want to thank all of the public health family, local government leaders, members who are on the call. From my role as the regional director for London, we could not have achieved what we achieved without your passion, without your leadership, without your focus, without your advocacy for local communities, for the role of local government, and for strong partnerships with all system partners, from business to communities, the NHS and public health. And certainly in London, and I know across the country, it has been those partnerships which allowed us to go further, to really ensure that we were responding to the epidemic in a concerted way, and to have a very clear narrative of feeding back through local and international about what works, what's feasible, what's not feasible, and what needs to change. So I'd like to also begin by thanking colleagues for that. I agree with everything that Jim, Robin, and Shilpa have said about how fundamentally our relationships have changed. And we're going to emerge from this pandemic with, I hope, deeper, stronger, and far more comprehensive relationships, and perhaps even more complex relationships that we entered the pandemic with. And I'm hoping that these relationships will form the basis of a foundation for moving further and faster with recovery, and that it puts us in good stead for addressing other health issues, which we know are going to be key as we move forward. So in my reflection today, I wanted to frame my thoughts around 4 key questions, dealing with how do we build on the legacy of how we engage with communities. Second, how we take full advantage of public health reform. Third, what are the opportunities in this phase of the pandemic, and how do we ensure that we're leveraging those opportunities? And then finally, a brief reflection on some of the risks and challenges that I see in the system as well. Now, one of the defining characteristics of the pandemic has been inequalities. And it has been certainly from the beginning of the epidemic, when we began to understand the inequalities of risks and outcomes with people who are diagnosed, develop severe disease, and die from COVID. And with each phase of the pandemic, as we've rolled out the test and trace program, as we've rolled out the vaccination program, we have seen the influence and the impact of inequalities on all of those programs and also on outcomes. And a key part of what I think directors of public health have been able to do, have been able to have a strong and concerted voice to shape national policy, to shape the national programs, and to ensure that the response has been grounded in the realities of local communities. So as we think about the legacy of the pandemic and how we move forward, I think there are three things which I think will be key for us, working both with directors of public health and local authorities and local public health systems. First is how we build on the strong engagement and community relationships we've developed, especially in the past year with the vaccination program. For many communities, as we've been doing engagement efforts with our directors of public health, we've heard that this is the first time that communities felt at the table, discussing some of the difficult issues, being able to raise some of the challenges on how the health and statutory sectors have engaged with communities previously. And therefore, we have a chance now from that place of honesty and authenticity to build our relationships. We can bring those relationships and that deeper connection with communities into the emerging ICSs and the priorities of the NHS. And while I agree with Jim that the role of public health is not only to serve the NHS, we do have an amazing opportunity here with the creation of the ICSs and new partnerships between local government and the NHS to shape this and to ensure that lessons learned about community engagement, mobilization, the ways in which we use asset-based community development in our work to inform the work of the ICSs. And thirdly, with our communities, to be able to pivot from the engagement that we've been doing on COVID to some of the wider health issues, some of the tough issues that perhaps we haven't engaged communities with before, or not to the scale and depth and level that we need to see change. The second question then is the public health reforms, and Shilpa, you reflected on in the middle of the pandemic having to go through both the ending of Public Health England and the creation of 2 new public health agencies. And again, I think directors of public health, because of the voice, the advocacy, and the focus that they've brought of ensuring that their perspectives were fully felt and fully heard in national policymaking, I think we have a really good foundation and base on which to build the relationships with both the UK HSA and OHID moving forward. And key among these is the focus on place. So Robin, I agree entirely with you about the importance of place shaping the national agenda, shaping national programs, and holding to account the resources, the priority areas of focus, as well as the ways in which those programs are going to be delivered, but also ensuring that place-based priorities form part of the priorities for OHID and UCSA. Another priority for public health reform will be focusing on the wider determinants of health and understanding how, with the new agencies which have been created, the commitment to work across government in health and all policies, that directors of public health's voice on how do we tackle the wider determinants of health, what policy, what legislation needs to be in place will be key. And linked to the reforms will be new opportunities for cross-government working and ensuring that directors of public health and local authorities help shape the priorities for cross-government working and health in all policies at the national level. And we bring our local and regional experience to our national colleagues based on our experience of the pandemic to help to shape those agendas, ways of working, and the ways in which programs and priorities get implemented. So within this, we're coming now to a new phase of the pandemic. And I think, there is a real risk that as we approach this next phase, as we get to winter and prepare for spring, that there's going to be a risk to both disinvest, change priorities, and to think about the recovery that is necessary. And I think directors of public health, again, have a key role to play here. My first and largest ask is a constant reminder that the pandemic is not yet over. And I think it is challenging for us as we are navigating relatively high prevalence, high numbers of cases, pressures on the NHS and local systems, that the voice and advocacy of local government and DCPH on the continued need for prevention, testing, contact tracing, and the pandemic response remains key. And a key part of that is ensuring, again, that your local voices are influencing national policy. And a great example of this is ADPH's work on helping to shape policies for reducing infections in schools currently in this phase of the pandemic, and helping to shape winter preparedness. And again, as we think about this phase of the pandemic, really working with OHID and UCSA as we develop the national policies and priorities for these agencies to ensure that the directors of public health perspectives and local government's perspectives are also reflected. Finally, I want to reflect on a few risks and challenges that may face us as we embark on this journey, as we approach both the end or this new phase of the pandemic, but also establish a new public health system. The first is on resourcing and ensuring that as we shift from the pandemic response to recovery, we have the resources in the right organizations, in the right places to deal with the multiple challenges that we're going to have ahead. And those resources are not just financial, but also, as we heard today, in human resources as well, dealing with and supporting an exhausted workforce, a workforce that has been under sustained pressures for a significant period, and helping to think about the future generations of leaders and workers and staff and colleagues in public health. We must learn about the lessons from the pandemic and to think about how we continue to implement these in our work. And a failure to actually build on those lessons learned will be a risk and a challenge for us. The tendency to want to revert back to the way we were, or the pressures of individual organizations and systems to deal with their individual challenges will be a risk to systems leadership, system partnerships, and coordination. And together we must work to ensure that we commit to building upon these lessons, commit to new ways of working, and to build upon these new relationships that we've developed throughout the course of the pandemic. So Catherine, thanks for the invitation, and I'm looking forward to the discussion today.
Thank you, Kevin, and again to all of our speakers. And so much to say there. So many different directions we can go in. But one of the things I just wanted to pick up on was, Jim, when you talked about a DPH isn't just for COVID, I thought that was really powerful and could probably be the name of this session. So it would just be interesting to hear your reflections, I suppose, on particularly that point around the increased public visibility and kind of reputation, enhanced reputation, both within the local authorities and with the public that the report picked up on. So I think partly drawing on a question that has been asked already, but also just that kind of point that Kevin just made about how we kind of keep up the momentum. What kind of reflections do you have about how DPH can kind of build on the enhanced visibility and reputation that they've had during the last 18 months? And maybe I'll come to Jim and then Robin on that one.
I think the the word covenant is springing out at me. That one of the things that's, I mean, most DPH have had hate mail. Some of us have had harassment, but we've also had thanks. And the things that spring to my mind of the last 18 months are the 90-year-old person I arranged a test for because otherwise they wouldn't get the cancer treatment, and the little things. And that springs to my mind, the concept of covenant relationship is that you have to be set into the local system, you have to be part of the local system, you have to orchestrate elected members and be part of that. Everybody now knows who a DPH is. That won't last. You know, it won't last, and it's probably a good thing, because we shouldn't be the superheroes. We should be one more part of what your local public service does to enable you to have a good life. So a bit of covenant remembrance, a bit of having your community at your heart, a bit of staying relevant and listening to what your community wants. Get inside the heads of your elected members, because at the end of the day, they represent your community, not me. I'm here to serve, I'm not here to represent. And I think my dad used to say, my dad was a bus driver, and he used to say, you're no better than anybody else, but nobody's any better than you. And I think remembering that, and a bit of humility, and setting yourself into the local system, because the worst possible thing we could do is not hold that as precious in our hands. Everything I'm saying is about personal disposition rather than techniques, but all of that follow. And I think develop our leadership styles accordingly would be my advice. I hope that makes sense, because for me, this feels very deeply personal.
I think it has to be, doesn't it? Absolutely. Thanks, Jim. That's really helpful. Robin, do you have anything to add to that?
I think there's something about Jim's humility and understanding of the way that public health operates in a sense of sort of being and identity and belonging, and a sense of respect for each part of the system. So I think there's something about the relationship with members as elected members in local government that's fundamentally shifted through the pandemic. So whilst I've sort of said when I spoke, a lot of this we already knew, a lot of this we already had, we probably weren't capitalising on the opportunities for public health in local government and public services, and certainly local government coming home. I think there is something distinct and different now about the understanding, recognition of the role of public health for politicians at a local level and also at a mayoral level. I've just been responding to a question on that, which is the opportunity to operate at scale in a way that is really, we have to make it happen. It might not happen. I have to say there's a real risk it might not happen. But if we're thinking about designing a transport infrastructure system that's going to be fit for the next 30 years, if we're going to think about the skills of our young people and the scarring impacts of the pandemic and the public health thinking that we need to build around planning, evidence and system working, I think, you know, skills is an opportunity that's really, we could grasp around work, the role of work in well-being, in health. I think we've missed some of those opportunities and we've got to build on that politically and also with colleagues. So it's all to play for, but it won't happen automatically. I think those of us advocates who care about this have to make the case really strongly.
Thanks, Robin. Yeah, absolutely. And I just wanted to pick up on that conversation you were starting there about health inequalities and that kind of the fact that obviously, I know we talk a lot about the pandemic shining a spotlight on health inequalities and starting a conversation about how we might be able to address some of those wider determinants, but also kind of recognising Kevin's point that we are still in pandemic response mode. It would be interesting to get some reflections on, I think, what Shilpa picked up on in her report summary about that business as usual point and that kind of how do we make sure that we move back to business as usual and make the most of that opportunity that's prompted by the conversation that's now happening about health inequalities and try and do everything at once, also recognising the pressures that individuals have been under for extended periods. I don't know who wants to come in on this one.
Shall I kickstart?
Thanks,
Catherine, I think you're absolutely right. You know, I often say when we know better, we must do better. And I think the pandemic has so shone a light, not only are colleagues working in health and social care aware of these issues, but now we speak to any partner in London, any partner, whether in business, in the faith community, local communities, education, they understand inequalities in a way that perhaps there wasn't that understanding before, and they are engaged and are keen to understand what they can do and how they can be part of addressing them. So in the city, I think we've taken 3 key strategies to help with this. The first is ensuring that we have a clear sense of articulating what the nature of the inequalities are, not just with COVID, but the wider inequalities, and to have a shared vision and strategy for the work that we need to do. And the Mayor's Health Inequalities Strategy for London really provides that overarching frame for this. We're currently updating it to take into account the experience of the pandemic and the new lessons that we've learned. And that will become an overarching frame for us in London to begin thinking about collectively, from whatever sector, how do we align our efforts on inequalities? Second is ensuring that we have the right governance in place as well, and the clarity about the asks of each of our partner agencies and what they need to do in tackling inequalities. And I think this is where directors of public health have a key role to play in helping local community organizations, the NHS, social care, education, etc. All those sectors, either through health and health policies or the governance that we create to build those relationships to focus on inequalities will be key. And I think one of the most common questions I get is, all right, Kevin, we want to do some work in this area now to address inequalities. What do we do? How do we get the data? How do we understand what works in addressing inequalities? The third thing to reflect on, and again, this is where we're moving in London in terms of not just the strategy and governance, but is ensuring that we coordinate better, that we share best and emerging practices, not only within London, but learn from other parts of the country. and we think about creating communities of practice that begin to think about this. And again, directors of public health do this locally, and we have a chance to build on that strategically at the regional level as well. So it's about how we learn, how we become more agile, how we share new approaches, how we learn from the pandemic and translate that into other programs, and how we work to hold ourselves and our partners to account in this area. So I think, there are a range of things that we're thinking about in the city, many of which we're already beginning to implement to help us to really take advantage of the lessons that we've learned on inequalities with COVID.
Thanks, Kevin. I think everybody wants to come in. Jim, can I come to you first, then Robin, then Shilpa?
Thank you. I'd agree with everything Kevin said. The only things I would add would be inequalities are about what the system does, not what the DPH does. And the idea of the DPH there is a servant to the system, set into the system. I've never been comfortable with the model of the DPH as independent from local systems because it feels like a medical model. And I think the idea that inequalities is being about what the DPH does feels like an interventionist model rather than a systems model. So we need to rethink our models. We have huge resources out of the pandemic. So locally, we're continuing our health protection board. We've harnessed local communities. So we got our traveller population's vaccine coverage up to over 90% locally. We've done a huge amount of things. The great legacy of the pandemic, I think, has to be an ability to focus on inequalities because we've got an understanding of it that we've never had before. But we can only do that together. And the DPH role in that needs careful discernment.
Thanks, Jim. Robin.
Yeah, I just say, it feels we're very, very far away from business as usual at the moment, if in terms of the health system and the NHS. And the challenge, I think, is not being able to learn what we've learned and implement what we've learned. I think that the real struggle, and I see it in terms of the kind of demand system pressures that are faced, means that it's a real battle. And I think that there is something about sort of the troublemakers of public health being encouraged to be troublemaking and to be not losing sight of this. And I don't think it's because people have shifted. So in West Yorkshire ICS, we did a review with Dame Donna Kinnear about the racial disparities, the racial inequalities that the pandemic, the early phases demonstrated. We've got a plan, we've got actions, we're delivering on a lot of that. However, the sheer scale of demand and the challenges that we're facing that I've been in this morning around our system, every part of it, acute, secondary, tertiary, community pharmacies, every single bit of that system is at the max, and we're in mid-October. So I just think that the need to work alongside, to be alongside, but not just to kind of revert back is a real risk at the moment. So I think we all have a part to play in dealing with that and supporting people not to do that. Thanks.
Thanks, Robin. And Shilpa, did you want to come in as well?
Yes, very quickly, because I think I'm just echoing what others have already said about really learning from the pandemic. And one example I'd pick out is that I think is relevant to tackling health inequalities is the relationship between public health teams and but also other sort of perceived authorities and local people, and how taking a more sort of targeted and tailored approach to engaging with different groups who have poorer health outcomes made quite a difference to vaccine uptake rates, testing rates. So yeah, as I said, just echoing what others have already said about learning from those good examples.
Question, which has been a very popular one. I noticed in this answering this question, I think all of you have used language around inequalities, and I just wondered whether anyone has a view on the current language and changes in language that we're seeing a rise in the use of disparities. Jim, I can see you've got your hand up. Would you like to comment on that one?
Yeah, so at the risk of being unpopular, I can remember Health of Our Nation, And our healthier nation, when we weren't allowed to talk about disparities or inequalities, we had to talk about variations. And I sometimes have to go back to the sources and remind myself of the difference between an inequality and inequity and a disparity. I kind of wonder whether we're getting a little too hung up on language. And I know language is important, but we've got a Deputy Chief Medical Officer whose shoes I am currently filling on an interim basis as ADPH President, who has local and inequalities at her very core. You've got local at the heart of the new system. And I wonder whether the issue is, let's just be clear of the concept of what we're trying to achieve. And let's be clear of what the art of the doable is. Sometimes actually politically, if you have to use language you wouldn't otherwise use to get something through, that's a part of what a DPH does on a daily basis. Maybe we should just focus on the outcomes and not on the language. I'm happy to be shot down for that, but I think what matters is the people, and sometimes language can take us down a line that doesn't matter to those of us who haven't had the scientific training. And I work in an authority where we've got all sorts of parties, and they're all interested, cross-party interest in this. But they do look at public health language and think, could you translate that into English?
Thanks, Jim. So I'm hearing a call for pragmatism and a focus on outcomes. Kevin, would you agree with that?
Entirely. I would absolutely agree with Jim on this. For most of us not in public health, the distinction between disparities and inequalities, it doesn't resonate. People don't necessarily understand it. Now, we have a role to play in encouraging and educating and informing people on those differences. But let's not lose sight of what we have. Now, in addition to what Jim has said about the DCMO, the Chief Medical Officer and Secretary of State have come out absolutely clear about the importance of tackling disparities and inequalities. The Secretary of State is clear that one of the first outputs of OHID will be a paper which will be focusing on how we tackle the inequalities, disparities emerging from the pandemic, and ways in which the system will work together to tackle these. So we have an amazing opportunity now of a team in government with the title of disparities, emboldened and empowered by the Secretary of State to both develop policies and to work across government on this mandate. And I think that's incredibly exciting. We also have, as Jim has said, just the network now and the experience of coming through the pandemic with a workforce, with an army of partners who are now engaged on issues related to inequalities and disparities. And the key test will be how we translate our thinking nationally from OHID into the real world realities of what's being done locally, so that we can have a golden thread of this. So whether it's inequalities, wider determinants, disparities, that shapes and forms our policies and programs at the local level where it really matters. So I think, recognize the triumph that we have here in an office in government, in this administration, with disparities, recognize the assets that we have, and really think about how we leverage them to make that difference in our programs locally.
Thanks very much, everyone. I think that was a really helpful discussion. I want to start picking up some of the questions that are coming in, but just before we get on to those, I think there may have been a question about this anyway. I just wanted to pick up the conversation that some of you started around ICSs and the opportunities posed by ICSs. So it would just be good to get some insights, I guess, into your experience so far on the conversations that are happening in ICSs, and also, I suppose, the risk that Shilpa flagged in her report around duplication between ICSs and conversations happening in local authorities. Any volunteers to come in on that? Jim?
Oh, go on then.
You were off mute. It's always dangerous.
I know it's very dangerous. I'll learn next time. I can see Kevin laughing because he escaped. So I'm the population health SRO for an ICS, and having been an NHS director, I think there are some real opportunities, and the real opportunities here is to harness a system of players, including acute trusts and mental health trusts, to really put health outcomes, the reduction of unwarranted variations and inequalities, and a whole load of other things first and foremost. I think the risk we have is we end up playing governance games, and we end up tying ourselves in knots over packs of papers and duplicating and multiplying meetings. And this is not a criticism of the NHS, this is just a criticism of what happens when systems change. And we lose sight on the focus. So for me, the acid test of whether I've been any good in the NHS is whether I've reduced amputations in people with type 2 diabetes by a third over the next 3 years. It's whether I manage population blood pressure better. It's whether I actually really address some of the deep-seated inequalities in outcomes. I do feel as if there is a move to reinvent public health under the name population health, and they're not the same thing. And population health management is not a clinical prevention. And so my watchword would be, you don't shift the health of the public by pumping more and more money into treatment. You have to get into prevention, and we need to learn that. So if all we do at the end of this is come out with yet more money going into treatment and not an absolutely deep-seated emphasis on prevention and better health, we won't deliver the outcomes our population needs. I hope that makes sense. But so it's a difficult balance, I think, that our NHS has to strike, and they will do it if we're absolutely 100% with them in the focus on both clinical and population outcomes, not just treatment.
Thanks, Jim. I'd imagine, Robin, you agree with that, but tell me if that's not the case.
Yeah, I do, and I think I just add to what Jim said. I think the problem is, I mean, having come into the accountable officer role within about a month, having the paper to the NHSE board about the end of effectively the end of CCGs. So spending most of the time exiting an organisation. Just to say that the sheer drain of time and energy on structure, governance, and people is not been ideal. And the timing maybe has not been ideal. However, there is an opportunity, if we kind of use it well, to move away from an argument about geography, about what we do, and actually think about, well, if we think about system transformation, collaboration, owning things in a different way and sharing knowledge and understanding. And I think the population health, I think Jim's right about population health, not public health, but I do think the population health conversation has helped that in ICSs. And seeing something around the work we're doing around climate change, the work we're doing around homelessness as fundamental to health and care systems and not an add-on. So there's a whole set of opportunities. I think we're just going to go through this bump as we do with a structure of diverting a lot of time when we could be thinking about other things. But I do think that for a West Yorkshire population of 2.3 million, where there's also a coterminous geography with the combined authority, and the connection has to be ICS and combined authority, that there's some opportunities, and we're creating a joint post in public health to work across the two, to make that work, health, place connection and build that understanding. So it's all to play for, but let's not hopefully just see the same sort of performance management sole focus translating from a national to a regional to an ICS, but let's see a different duty to collaborate, opportunity to collaborate, I'd say, opportunity in the ICS. And it's all to play for. I think with good people and good relational focus, we can make this add value. Thank you.
All to play for. That sounds, yeah, a good summary. Kevin, anything to come in on that?
Yeah, so we're working in London with establishing our ICSs and really asking some tough questions about how we embed and strengthen that population health and public health expertise and input into the organization in this formative stage. So 4 very quick things. The first is, the DPH resource is a scarce one, and they're going to be pulled in many different directions as we emerge from this pandemic. And one of the real world issues we're seeing is the time it is taking for directors of public health to get engaged with the ICSs because they're pulled in so many different directions. So there's work that we need to do together to be absolutely clear about how and where public health leaders find themselves within the ICS governance chains and what can reasonably be expected of their work and leadership in helping ICSs as they develop. Second reflection is around prioritization within this. There's going to be a real tendency to want to do everything. And I think public health expertise can really help ICSs to focus on the things which are both most important, but understand the evidence behind what works and help to really focus resources and time and effort on the things that matter. And this is going to be important for clinical and community preventive services and inequalities, but it also will be important for our public health staff to bring their expertise and community engagement in place in leveraging wider assets from housing to education into the ICSs, working with local authority partners so that the ICSs can truly, I think, achieve their goal in improving population health. And then the final thing I think we need to really reflect on is what are the delivery mechanisms for ICSs in order to improve population health? And how do we leverage assets beyond the NHS and local authorities in helping with that? And I think that's going to be a real opportunity for us to be clear about our model, how we work, and how we deliver impact. And I'm hoping that public health will be a key part of that discussion too.
Sounds exciting, something to watch, I think. So I think we're going to be moving on fairly shortly to the video, but before we get onto that, I'd wanted to pick up these questions that have been asked about what we've learned about engaging with communities that we haven't traditionally engaged with as well. So I think people have been asking about whether we've gained the trust of some of those communities, I guess what's worked in doing this, and how do we replicate that going forward. Shilpa, can I come to you? Is there anything that the research picked up on this that it would be useful to feed back?
So I think from the experience of directors of public health that we heard about, it's definitely key to take a targeted and tailored engagement approach. So it's not the case that one size fits all, and it really needs some thinking through about different ways to connect with different community groups. But keep in mind, it did help encourage and drive up testing and vaccination rates. And it's really important to give this time. It's because time is really needed to make this a conscious, a considered, and a consistent activity. So it's not, so community engagement like this shouldn't just be left for pandemic times in a sort of we must pay attention to what's happening with community groups. This should be, present in mind at all times.
Yeah, absolutely. I was listening to a podcast that the King's Fund did, I think, actually, with Tracy Dashkovitz, who formerly DPH of Salisbury, now of OHID, who was talking about forming relationships in peacetime and the importance of that in the context of emergency planning. But actually, I think you could probably see across all of the relationships we've been talking about today, it's got to be the business as usual. Any reflections from anybody else on that point about lessons learned about community engagement, particularly with communities that we haven't engaged with as much in the past?
Yeah, Catherine, it's Robbie. There's a whole hard to reach debate. It's not, services aren't necessarily geared up to be where they need to be, to think and operate in the way they need to be. I just want to pick one out. I think that's been really powerful around primary care. There's been, and one thing we haven't mentioned around the pandemic, the impact of people with learning disabilities, and some of the ways that I think primary care sector, the system, primary care colleagues have worked with. We've moved from a sort of learning disability health check, tick or not, into some really deep relationships with I hope we can build around our primary care networks, consolidate a different way of working with people with learning disabilities. I think it's not talked about much, but the sheer scale of impact to that population has been one of the devastating things about the pandemic. And so I think there is something about trying to capture that relationship, that understanding about how to engage, how to build trust, and how to make services more accessible, that I hope we can build and sustain and not lose. And I'm quite optimistic about that particular piece of work. Thanks.
Thank you, Robin. I'm afraid we're running out of time. So I want to take this opportunity to thank all of our panelists before we move on to the video. Thank you again, Shilpa, for the work, and thank you to all our other panelists for discussing the work and having such a rich conversation. And thank you all also to everyone who submitted questions and commented on the questions. I think I haven't had time to look through all of it, but again, I think that's a very rich conversation that we'll reflect on. I'm going to ask now the events team to share the video, and we'll have that just before we wrap up. So what you're going to see now is a video of a poem that's been written by Alice and Emily Wiseman. Alice is the Director of Public Health for Gateshead, and you'll hear her voice reading the poem, along with Rachel Flowers, who's Director of Public Health for Croydon, Stephen Gunther, who's Director of Public Health for Walsall, Sandra Husbands, who's Director of Public Health for Hackney, and Helen Lower, Director of Public Health for Bolton. It's a really powerful poem, and I think it really brings to life a lot of the issues that we've been talking about today, and also that point that actually what we're talking about is very personal. It's personal for everybody who's lived through this, whatever their perspective on it has been. So enjoy.
January 2020 started with a bang as a deadly virus was found in Wuhan. Was this the pandemic we'd read about in books? We watched the news, sometimes scared to look. Pandemic planning and preparedness. This was the task of our lives.
It spread from coast to coast and over the seas with terrifying ease and agility. And we woke to a world we wish we'd never see. Pulled out those plans that we hoped we'd never need. We kissed our families goodbye, no such thing as ready, and rolled up our sleeves, vowing we wouldn't be defeated.
In those first few weeks as we watched it sweep around the globe at tremendous speed, it was a fight to try and stay in the lead. Our communities no longer free. A lack of testing left us blind to the spread of the virus and its fierce incline.
Lockdown was announced after feverish debate. Some thought too early, some thought too late. But our people were heroes, pulling together with might, enough to illuminate the darkest night. And the blue lights came out to back up our plan. Boots on the ground was the call of our new plan.
Rainbows in windows and clapping in the street gave us a boost, kept us steady on our feet. PPE was scarce, managing risk became the game. And if you were feeling afraid, well, there was no shame. Hands, face, space became the mantra of the day. Who would have thought how much those simple steps would pay?
Our care homes felt it next, and while they didn't groan, staff, residents and their loved ones felt neglected, alone. Our nurses stepped up like soldiers to war. Protecting those most vulnerable was all they battled for. And they stuck together all the way through. No one asked whose job it was, but instead, what can I do?
Businesses worked around the clock to keep the virus from the doors, to make it stop. And our teachers, they learnt overnight to be contact tracers, testers, and to educate in spite of their classrooms being empty, all the children being home. They didn't just worry about schooling, more the kids who are left hungry or alone.
Then just as we thought we could do this no longer, the vaccine arrived, which made us feel stronger. With hope in our hearts, we entered December, with thoughts of a future which C-19 wouldn't enter. But our dreams turned into misery. Cases rose and caused death and injury.
When January came and our spirits were low, our key workers tired, frustrated, left out in the cold, and the doubters came out with their words of resent, increasing numbers fueling bitter dissent. Targeted with disinformation via Facebook and Twitter, armchair epidemiologists thought they knew better. But still we ploughed on with steadfast endeavour, wishing this virus would leave us forever. After the snow came the spring, and cases started to fall, forever grateful to all those who answered the call. People felt divided on the next track, some asking caution, others wanting to get back.
We know it isn't over,
but it's time for revolution.
Come join us with action, be the solution.
Let's feed the hungry and house those with needs.
Help the folk up who are down on their knees.
Stand up to those who fuel the divide.
We are better together, standing side by side.
Well, it's lovely to see such lovely comments on that. I think it is a very powerful piece, and yeah, thanks to Alice and all of her colleagues for that. And we will pass on the positive comments that have been put in the chat because I think she'd really like to see them. So thank you. People have been asking where that's available. I think all I can say for the moment is that it will be available on the recording of this webinar. So at about an hour and 10 minutes in, so that'll be up on the website tomorrow. And it could be that Alice is looking at other places to put it. But for the moment, I think our webinar recording will be the place to find it. So I think there isn't really much more to say after that. I think that kind of is a good note to end on, really. But thank you again to everyone who's been part of today. And just a quick advert really for our website and for the Health Foundation events. We have a series of webinars like this one. The next webinar is later on in October on NHS recovery and how we can indeed build back better. So do have a look for that. We've also got a lecture with Dr. Hilary Cottam coming up on social care. Obviously a big issue at the moment. That's on the 2nd of November and you can find out more details on the website. But I hope you've all enjoyed the last hour and a half. I know I have, and lots of food for thought there. So thank you all for your participation and look forward to seeing you at future events. Thanks very much, everybody. Goodbye.